Welcome to the PTR Physiotherapy Rehab Podcast. My name is Warwick Schmidt, and in this podcast, we interview subject matter experts, authors, and elite athletes to help inform clinicians and patients and generate discussions around sports, rehab, health, and how to get people back to their best. We hope you can take away some content and use it in your practice. Okay, welcome to the PTR Physiotherapy Rehab Podcast. We have two great guests today, Damian and Liv, who are both working or have experience in Rugby 7's. And today the topic will be focused mainly around the difference between 7's injuries and 15's and how we can differentiate their assessment and rehab and get them back on the pitch. So if we can introduce ourselves, I think we start with Liv. How did you get into physio? How did you get into 7's?
Yeah, sure. Thanks for having me on the podcast. So I got into physio, straight from school, went into uni, studied physio. I was super into sport when I was younger, and I knew I wanted to do some form of healthcare, so it kind of just made sense to go into physio and then with the goal to go into sport. And then so within the UK you do a lot of NHS work, and I hated it. I hated the hospital work at uni, if I'm honest.
Not for everyone, is it?
No, it's not for everyone. And then so I was like, well, I want to go into sports, so I just need to go shadow someone who is in sport. So went and did an experience in the summer, literally just shadowed a physio in a summer 7's series just in the UK. And it just so happened that through people, he so happened to be the England 7's physio at the time. So kind of grabbed onto him and just nagged the hell out of him for a couple of years. And then he just, gave me an opportunity, networked me with other people to get experience in rugby. And then, I just kind of built up from there, really. Started as an intern physio in a semi-pro champ club in the UK. And then, built up from there to then go to Samoa. And then I was at Harlequins, went to Cardiff Rugby for a bit, and then, went to England, which is now Great Britain Rugby 7's.
Nice. And so the journey from 15's to 7's, that was conscious, or did you fall into that? Because we all start at 15's, really, and there's enough work out there. Isn't there?
So when I shadowed that physio at the 7's, because it was the 7's tournaments, when I shadowed them, I remember thinking, this is what I want to do. Like, I love it. The atmosphere, the environment. And I kept in contact with him. And at the time, the England 7 setup was incredible. So I spent, as I kept in contact with him, I saw their setup and I thought, this is amazing. You get to travel the world full time, like, you're really close-knit community. But obviously in 7's, you only really have, in the UK at least, the international format is where you get a full-time job. The levels below that, you don't have a full-time job in. So naturally, get experience in the 15's world. But then, flip back over to 7's when I got the opportunity.
Nice. So how long have you been full-time 7's then?
This is my, I've just completed my third season. So I came into the England setup just after COVID, because obviously all the 7's programs dispersed in the UK. Came January 22. So I'm going into my fourth season, because the first season was like a half season, essentially.
No worries. No, excellent. Damian, same question?
Yeah, so for me, it started a long time ago. At the turn of the century, I went to physio school down in Dunedin here in New Zealand. Again, like Liv, I always wanted to work in sport, and in New Zealand, the most opportunities that you have is rugby. Yeah. So when I completed uni, I moved back to the province I was from, Bay of Plenty, and just made sure I worked in a clinic that had the contract for our 15's team.
Smart.
So I started looking after some of the junior age grade teams, and I was a physio for the provincial 7's team, which was a good gig to have, because we used to have a trip to Queenstown, which was a good little trip at the end of the year. Did that for years, and then I managed to get the head job at Bay of Plenty Rugby, which is in our national provincial competition. Did that for about 6 years, and during that time, I'd applied for a role with the New Zealand under-20s and was successful with that. So I was with that team for 3 years, and sort of love the exposure to the national level. But it's a relatively short program, so I was still looking for a full-time job with one team, and then the 7's job came up at about 2017. So yeah, managed to jump over to the 7's, and I was with them until about 18 months ago. So January 2023 is when I finished up with the 7's. Yeah.
Nice. Oh, that's great. So with the role of 7's, if we go broadly into, you've both obviously, we've all kind of had, I mean, maybe to a much lesser extent, but 15's, we kind of know that there's very defined roles. We've got forwards, backs, even within forwards, there's different roles. Do you find that you see more of the same injuries with 7's, or is there still the same variety based on the position? Because obviously you'll have some of the bigger guys being in the scrum. Does that play a role, or do you find you still use your 15's knowledge for most of it? Is that to live? Does that make sense?
Yeah, no, it does make sense. Yeah, I find within 7's, you definitely get a lot of similar injuries as you would in 15's, but I would say more of the injuries you would get in 15's backs, because obviously you don't have the body shape of props, hookers, etc. Although you are scrumming in 7's, it's literally not a 15 scrum, it's very different. That being said, obviously you still get neck injuries in 7's, whereas they tend to be more common in that front three and 15's. I would say in 7's, obviously it's a lot quicker. So it's obviously you're working at a high speed. There's more accels, decels, change direction. So I tend to find that, and obviously there's less people on the pitch. So so obviously the types of injuries you get is very different to I say the prevalence of injuries, not the types of injuries. I'd say there's similar types, but the prevalence of injuries you get in 7's is different to 15's from my experience. The number one being concussions. Obviously I think they're prevalent in both 15's and 7's, but second to that, MSK wise, hamstrings are the most common I tend to find. Yeah.
Sure. I was going to ask that. I'd done a bit of reading, and I assumed with basically essentially sprinting, stop start, that hamstrings would be the one. Does that sound familiar, Damian, and your guys as well, girls?
Yeah, definitely. I don't really find in 7's that there's too much of a difference between the injuries that you get between the forwards and the backs, but because all the backs these days have to play a pretty expensive game and they need to run fast as well. So. Yeah, like Liv said, pretty much all the forwards that play 7's would be a pretty fast loose forward in 15's if they were, or a midfielder. So, the slower speed in the 7's team is still generally pretty fast.
Yeah. So it's the top end of the 15's, I guess. Yeah, you could substitute those for backs or something. So if we got a bias towards more sprinting, more dynamics, more plyometrics. Do you find that you are doing almost a plyometric sprinting? You could kind of copy and paste an athletics rehab program into a 7's program because of their hamstring and their power, or do you find that there's a difference? Are there other ways that you train them? Does that make sense?
Yeah, I wouldn't plug and play, but it certainly looks a little bit more like an athletics rehab program than a traditional 15's. So emphasis is on speed and shorter durations, whereas 15's might be long distance, longer duration training. We're on the field for a much shorter space of time, but we're just running fast for a large majority of that time.
Yeah, no, that's it. And if we do, somebody comes off the pitch, they pull up. In terms of the getting them back running, so from there back to running, do you have any outcome measures that take them from acute to mid stage where they can start jogging again? Have you got any kind of measures that you use to go, let's get you jogging again?
I think I think if someone, so a hamstring specifically, then I think obviously at hamstrings that it's the higher speeds that put more force through them. So it's kind of when for me, I tend to say 80% plus is when you're actually going to stress the hamstrings most. So below that's actually low speed running. I tend to be quite comfortable with a low grade hamstring assist for them to get running quite quickly. So if it was a grade 1 hamstring, for example, if you take out the T junctions of bicep fem, because I think they're a little bit more tricky, but the other types of hamstrings, if it's a grade 1, just a simple simple hamstring tear, then I tend to find that you can you can get them running within a couple of days. That's my experience. I don't know, Damian, if you found different, but
no, definitely the same. In terms of outcome measures, we changed a lot over the time. Nothing really that I would say that we had felt like we needed to stick to. So long as we're sort of returning to normal length and pain-free walking, then and progressing through high intensity stuff on off feet on a bike or something similar. And then basically just slowly progressing their running speed and seeing how they're tolerating. We use GPS, or we used to use GPS quite a lot to just manage that speed. And with live GPS, obviously you can control how fast they're running and making sure that they're not overshooting what you want them to do.
And do you with the GPS, which is really interesting, do you give them the feedback straight away so they are aware of all their metrics, or is it they're involved in the looking at the speeds from the GPS, or do you kind of feed back after a session and go, actually, do you know what, that was a little bit too fast? Or
no, for rehab sessions for hamstrings, the gold standard would be live GPS. So they might be running intervals past you, 30 meters or something, and you're basically yelling out to them, whether they're hitting that target or going too fast, so they can speed up. Yeah.
As they were doing the session, you can go up it, slow it down. With that GPS being kind of pretty modern, I guess it's been around for a while. In your experience, having been around for a little bit longer, what would you, looking back historically, do? Is there a big shift evidence base wise, or would you just go by feel back in the day? How would you have done it when you first got in?
The biggest learning, I think, that when we started to use GPS is that your traditional return to running programs that you might have done for a hamstring, you kind of underestimate how much total volume, total load you accumulate just by sort of running winders or running repeated efforts at building up speed and maintaining. And I'm sure we've probably all just had standard ones before GPS around what a 100-meter effort might look like. And then when you actually started getting some data from a GPS, you realize that's far and above what I anticipated I was going to get out of that session. So with GPS, all of a sudden my rehab sessions looked like they were a lot lower volume than what I would have traditionally done.
Interesting. Yeah. So they actually were working harder than they needed to across the session, and now we can.
Well, it's just not specific. Like Liv said, that you're really concerned about that running fast over the 80%. But if someone's had a decent hamstring injury and they haven't run for a week or so, and then the first session that they do, they might do, say, 3,000 meters, where they might only be running at 60 to 70%, but the cumulative load of that was way higher than what I anticipated they would have got without GPS.
Okay. Yeah. So then we're dialing that back down. Just maybe a bit more specific, I guess, isn't it? With that progress, I think what sometimes, if you're not used to using and being around those patients, if we had somebody would walk in and have a physio in a clinic would have somebody who's a runner, a sprinter, 7's, without having all this knowledge, we'd probably use manual muscle testing, or use a bit of palpation. You might use 10 rep max or 15 rep max with a band or a machine. Or do you still rely on those sort of outcome measures as a group, or do you said you go straight into running and then you use the effort levels? Do you still use the strength testing or manual or handheld dynamometry? I guess that would be also another topic.
So, I mean, you obviously still use your strength testing. Obviously, what you have access to differs from place to place. So, obviously, if you're in a clinic and you've got handheld dyno to look at peak strength, peak force, and then you've got like capacity tests to look at strength endurance, they're probably going to be your safest objective markers to determine whether someone's safe to go back running. But you want to look at I would say obviously the joint below and above. So you're not just looking at your hamstring, you're looking at how your calf's tolerating that, because obviously if your calf's not doing enough, your hamstring's going to kick in and do more work, etc. So from a clinic perspective, that's probably how I would do it. However, in our setup, we're quite lucky enough to have access to force plates, Nord board, etc., force frame, all those bits. So we can go into a little bit more of a deeper dive of peak force, but then obviously once you're happy that the hamstring is able to provide that force in the range that's specific to that hamstring, then you can then look at rate of force development. So looking at how quick they can produce that force, and that tends to give a better idea of the fact that the hamstring is able to tolerate going at that high speed and produce it, particularly if there's some tendon involvement. And then from that, you can then look at your plyometrics, obviously vertical and horizontal. That's probably how I would, from an objective perspective, look at it.
Would you, with obviously, without delving too deep unless you don't want to, but have you got any specific percentages of body weight or limb symmetry or outcomes that for rate of force development? So someone would be able to go, Joe Bloggs can do this on the testing. Let's move on to the stage, because it's good to hear that that's there, but sometimes the cutoffs and what people would use isn't always mentioned. So do you have any of that data or?
I off the top of my head, I don't. However, we did a pre-season testing last year for 7's, and we took all the like baseline data, looking at rate force development in a single leg hip extension, so a bridge position into that outer range, just looking at the force. But that was we collated that data more for an idea for us to have a baseline of someone sustained an injury, particularly a hamstring injury, to compare it to. But there isn't a huge amount of data within 7's out there. There's a lot of other data in sprinters and 15's, but in 7's specifically. So you tend to compare your data to 15's backs or to sprinters, and you kind of in that in between, go between those two.
Okay.
Yeah, off the top of my head, I haven't got anything. I can't think of the specific data.
Okay. Do you have any more on that, Damian?
No, I agree that even within a 7 squad, you might have 20 guys training there. There's still a massive difference between the type of athletes that you've got. So, yeah, it's a bit of a poison chalice to try and compare people to normative data. So, just using limb and symmetry is the easiest way, and trying to get at least over 90%, ideally over 95% symmetry is the other side. But we were the same. We'd keep baseline data and just try and compare that athlete to a previous known point. Some of our guys have been playing rugby for a long time, and they've got previous ACL injuries, so they've already got asymmetry. So if we can compare to their baseline as opposed to compare to an uninjured side, just gives you a little bit more accuracy. And just going back to a point that you mentioned before, just want to make it clear that we're not going straight back into running. These are kind of rehab streams that are happening concurrently, like looking at their strength once they're hitting all their strength markers. And earning the right to get back on the field and do some rehab running. So we'll be looking at all these objective measures sort of almost simultaneously, like their range of motion, their strength, their power.
Okay.
And just actually it sounds like we've probably got the same valve suite. So all those same things that we were looking at, using the force frame too for different angles of knee flexion for hamstring strength.
What angles would you be looking at or focusing on for these patients?
So we would have So we're looking at pretty close to 15 degrees knee flexion as well. So pretty much a knee extension, hip extension, but then also trying to see what you like with a knee dominant action. So knee at 90 degrees and prone using the force frame.
Okay. Is that like the break test in that regard, or is it slightly different then?
Slightly different, but again, you could do a break test with the handheld dyno.
Yeah, and then in symmetry. No, it's just interesting because you look up to people working in international sport, and obviously there's a lot of work that goes into it. But it's just nice to know that somebody in a clinic somewhere can also can use mostly the limb symmetry and strength testing and strength endurance stuff that can get us most of the way there, which is really useful. In terms of the strength endurance, Liv, you mentioned that you also got to make sure that they can get off the ground quickly and move. But the endurance side, what are we? How many reps are we aiming for, and what do you want to get the guys doing?
So if you're if we're looking at hamstring specifically, so at 90 degrees hip flexion, 90 degrees knee flexion with your foot on a box or a chair, whatever it is, and you're doing a single leg hamstring bridge with your arms across your chest, you're kind of aiming for at least 25 reps each side. We tend to, if we are looking at strength endurance, when I've done it in a clinic previously, I've set a metronome timer to 60 beats per minute. So obviously you go up for one, down for one.
Metronome takes it up, it makes it a lot better, doesn't it?
Oh, so much better. And then
because
then people cheat. Everyone wants to find an easy way of doing it. So it just makes it a lot easier. So that's what we're aiming for. And then you're aiming for, if you're looking at a single leg calf raise straight knee, then looking at 30 reps each side, I tend to say. And you tend to, like Damian said, obviously you're earning that right to run. So if you're going at those lower speeds, you're looking at the endurance of those muscles that they're able to tolerate it. Because if you're not increasing intensity, then you're going to increase volume instead. But obviously those tissues need to be able to tolerate that volume. So you want to make sure that the hamstring can do that, the calf can do that. And then obviously once you've built up the capacity of those tissues, you can then increase the intensity by doing the test to support that they have the right to do that.
Yeah, oh, that's great. I think that's just knowing how to then move them on is also that useful bit. I guess it builds confidence for them as well. It's probably something that they suffer with. You mentioned earlier, just slight deviation, Liv, with the long head, short head, biceps fem tendon junction. We've listened to a couple of podcasts on it, and a couple of people mentioning that it increases the level of complexity of the rehab. First off, with the assessment, this is for Damian as well, what gives you your gut instinct that this is there rather than a standard tear? Have you got any kind of ideas or ways that you would assess it with that?
I mean, I think location is the biggest telltale. So obviously that distal lateral aspect, and you palpating it, you can obviously feel the long head and the short head. Whether you know it's specifically that T junction, you don't until you have an MRI, which we obviously have the luxury of doing. So I think that, and then also the mechanism tends to be a pretty big telltale as well. So kind of in that sprinting mechanism, when they go into that stance, getting confused in my phases now, when their heel hits the ground, then you tend to, in that outer range position, if they've overloaded through that, you tend to have they feel the pain, obviously an injury through it, then you have the idea that that might be the area that's injured. Not always, obviously that's that coincides with the location of palpation. But I think also with the T-junction injuries, I mean, it's chicken or the egg situation. They're saying there's an increased prevalence of it, but actually are people just becoming better at reporting it on an MRI? It's kind of like, have we always had them, but are we just actually more aware of them now? But I've definitely found in the rugby population, 15's and 7's, obviously 15's back, there's a high prevalence of T-junction injuries, and there's more research going into it at the moment.
Right. Have you had any interesting variations on that, Damian, or any guys that have had that specifically that you can recall?
No, but we're probably a little bit slower in the reporting on the MRIs here in New Zealand. So, but the thing I would sort of point out to the people working in the clinic is we tend to have a whole lot quicker access to MRIs and other high resolution imaging that a lot of people in the clinic might not have the luxury of. So for us, if there's any suspicion, we can just send off for an MRI and have a good look.
Okay. And it's found, there's a diagnosis, the reporting radiographer says this is the issue. What do you find tends to be the first port of call? Are they going straight for surgery? Do they do conservative at your level, at the elite, the best level? What tends to be, do you think, the first line of treatment?
We've found that, so obviously you've got your gradings 1 through to 4, with 4 being a full rupture, and then you've got your ABCs as well. That's a grading we tend to use. We've found that for T-junction specifically, if there's a tear, that doesn't have to be a full rupture, but if it's a 3 B3C and it's significant enough and there's a loss of tension in that tendon that actually there's a better outcome of it being operated on rather than not operated on, regardless of whether it's a full rupture or not. That's just our experience in the last couple of years, simply because of the reoccurrence rate of T-junction injuries. We've found there's a 50% reoccurrence rate of those injuries happening, so quite high. Very high. So we just because of obviously the separate innervation of the bicep, long head and short head is one reason why they think it might be happening. But so obviously in those higher grade ones we would operate. However, in the lower grade ones, conservatively, we would just manage it that way. But we tend to spend a little bit longer time in that acute phase just to allow scarring to happen. So hence why I said obviously previously we would get them, if it was a injury of a hamstring in another area, we'd get them running quite early. However, in T-junctions, you tend to keep them in that phase where they're kind of letting scarring happen, etc. All that a little bit longer than you would for another hamstring. Sure. That's just my experience with it. Quite cautious with them.
Any more on that, Damian?
Just surgery on hamstrings in general in New Zealand is incredibly rare. So it's very much predominantly a conservative rehab. And so if we've got any concern that this is not your typical hamstring or simple hamstring, whether it's central tendon involvement or not, we would just factor that in with our rehab planning. So just giving extra time to get through each of the stages, slower intention to run, delaying that early part. So we might present to the coaches this, athlete A might have this injury and we're looking at a 6-week return to play, but for this reason, this athlete, we're looking at an 8 to 9 week return to play, and just factor it right in from the start. That we're giving them wider targets or wider time frames to hit their targets, not trying to push them along too quick.
Nice. And would you then, you've given them the longer acute phase, they're given a little bit more TLC. Would you then use the same return to run build up, or would you be a bit more stringent on certain areas for those players?
No, it would be slightly different. So you might factor in more rest days, or days to recover from sessions. I have to say we didn't really have any that I can think of actually true T-junction, but like I said, this was I left 18 months ago. We were probably starting to hear about T-junction injuries probably my last year that I was there. So I don't know whether they've been identifying a whole lot more since I've left, but I can't say that I'm talking from experience.
No, it's a I guess with more knowledge it becomes a problem we can solve better. But yeah, that's really interesting. With the Demi, you mentioned before recording about the differences in the strength testing. So are we changing the return to play outcomes in a way? So your strength testing, the S&C guys, are they looking for slightly different metrics, more power based before they come out of the injury and back onto the pitch? And if so, what in your experience, what would you be wanting these guys to reach before you can say, right, you're starting? Jim,
good question. Are we still talking about hamstrings specifically, or?
We'll go general, and then I think we can tweak hamstring. Because if we're getting really interesting information out of you guys, and you're essentially becoming hamstring experts through it, then that's why not make it hamstring bias. So if we go general, and Liv, this is for you as well. So you got an average Joe physio. He's got a guy who wants to go to 7's. How do we best replicate return to play? They can go straight back to training.
Well, I think just to simply answer the question, basically you'd start with a rehab template with the end state in mind. So what this athlete needs to be able to do, what that athlete's particular strength is. So if they're a playmaker, that they might have a real strength in agility and burst, acceleration, top end speed, so that that basically creates a picture right from the start of what we need to focus on to get them back to their best. It might be quite different to someone who's playing prop in 7's. And then for each individual injury, having your list that may change over time around what you think is really important to be able to survive in a game of 7's and then thrive in their game, the way that they play. And so, each year I'd kind of go back and have a look at all those templates and cross off the list things that I didn't think were as important as I thought, maybe 2 years ago. And with new testing methods or new concepts, you might start adding in separate ones.
Okay.
So I always found it was an evolving beast around, what a return to play would look like. And the other thing we haven't really touched on, and Liv will, be able to attest to this too, is that the schedule of the year has a massive bearing. So you've got back-to-back tournaments. If someone gets injured on the first tournament, they're not going to play the next one, depending on the injury. But then you might have 3 weeks until they play again, or you might have 8. So, you're trying to fit a standardized rehabilitation plan into a non-standard calendar. So there's all these sorts of different bits of context that you have to be able to try and see whether you can actually make that work. And sometimes you can't. And that's the hard part of talking to coach and just say, look, it's too tight a turnaround to get this injury back.
Sure.
So I don't think I answered your question there at all, but maybe we can have a bit of go at it.
It's difficult, isn't it? Because so apart from your strength markers and obviously getting someone to return to play, return to sport, whatever that is, whether that's a 7's rugby player or someone else, you need to look at the demands and what of the sport they're doing and then work backwards from that. So if you've got a marathon runner who runs in this, I don't know, whatever time it is, then that's what they need to aim for. Whereas in 7's, it's, repeated sprint ability. They're covering 1.5k per game. But obviously a lot of that is in there, like over 80%, 70% top speed. They're not coasting very much throughout that. Then you've got to look at accelerations, decelerations, that they can tolerate that. So you break it down to all those bits and you essentially tick off that they are able to do that. So whether that's like a hard acceleration, a hard deceleration, that they can do change direction, it's ticking off the demands of that sport, the demands of the movement demands, etc. I think you tend to do your testing to then have confidence that they can then tick off the demands of the sport and then that they can go into the sport. But as Damian said, when you've got those time frames, it's not like 15's where there's a game pretty much every week, and if you don't make that game, then it's annoying, but you can push on to the next game. In 7's, it's like, this is a tournament, and now there's only 7 tournaments a year. So if they're not doing that one, then they're missing one big tournament, and that's going to have a massive impact.
Yeah. And in terms of that, the traveling circus, or however you want to visualize it, looks great fun. I'm sure it's probably not always for you guys in the backroom staff. But do you bring any kit with you to these tournaments?
So you have
definitely bringing,
So you have you've obviously have access to the gyms that the players would use when you are in these places. So that ticks off a lot of the equipment you would need. The equipment I would tend to bring. So I bring a handheld dynamo, just as like a strength marker, just so we've got something, just to give me confidence if I'm saying to a coach, they can play, that I've got something to back that up, rather than just guessing essentially.
Feel strong.
Yeah, exactly. I'd rather say like, okay, there's an 80% deficit or whatever it is, So that then I think that's obviously you have your like resistance bands, etc. But the fact that you have like a lot of equipment provided in the gyms, that's tend to be what I use. You tend to have a pool as well. So obviously if you've got any like contusions, corks, dead legs, etc., utilizing the pool to get pool running tends to be quite effective from that perspective. But if you have got those short turnarounds where it's only a week, obviously if it's a fascial injury or a contusion or something like that, you tend to be pretty confident you get them back. Otherwise, you're sending that player home if it's going to be longer than that, especially if it's at the beginning of the season. then why are you risking someone? Whereas if it's obviously Olympic qualification or relegation zone, something like that, then you may roll the dice a little bit more.
Sure. And with that, Damian, as well, you at that level, I assume as a physio, you've got your physio head on, and you can say that this is torn or this is slightly broken, or ideally not broken. But if a player with experiences, in a quarterfinal of a massive tournament, and they tell you that they're going to run on, have you found that happens occasionally? Or are they normally pretty good these days to say, well, listen.
Oh, no, it still happens. It still happens. I can think of a tournament where we're in LA, and at the start of the week, one of the players fairly obviously tore his hamstring in training, but he felt pretty good the next day, and he was trying to put his case forward that he'd be able to play in about 4 days' time. And we had a discussion about it as a management group and a medical group, and sort of said, look, I bet he won't, but if he wants to desperately try, then we set out a plan. All right, well, we need to have a fairly good result on an MRI, get through the training session and demonstrate that he can run fast and change direction and do all the things he needed to do. And it was all looking good right up until the last time that he ran fast on the day of the tournament. And surprise, surprise, sort of, and look, well, we look back at that case quite a lot, and I don't necessarily feel like there was anyone at fault. The player wanted to, give it a good shot. We had a good discussion around the likelihood of success. People understood the risks, and we sort of collectively made a decision that we would accept the risk and see how it went. But it went probably as we had expected it to, and as a result, he was unable to play. So look, it does still happen. And as Lip said, you do take a few more risks as you get close to pinnacle events and key parts of the season. Yeah, but it also, you can always fall back on it. It's such a brutal game, such a hard game, that if there's any real questions about whether you think this person is fully fit, they'll probably be exposed. There's nowhere to hide on a 7's field. The distance between defenders is too great. So if you can't turn and chase or step off one side, you're going to be leaking points. And
then it's a selection problem for the coach, isn't it? Because they're not keeping the team up, then makes it easier. I guess with that one, you covering your back quite a bit with with that case, making sure you covered your own backside, as it were, making sure the coaches were fully aware that you weren't 100% on it, and then at least when it happened, there was no one pointing the finger at anyone. With that, Damian, with that case, you were then using all of the evidence there, that just to make sure that was you were covered.
Yeah, it's probably not your main motivation to do that. No. You're making a sound clinical decision, but
no, exactly.
Sometimes it's there for you to try and convince someone that this is just destined to fail. But this guy had sort of demonstrated in the past that he could overcome some minor injuries, and he felt pretty strongly that he'd played with something similar before.
Nice. That's fair enough. He's had a crack. With the conditioning of the players, do you? I guess with most rugby and sports physios, you do have a foot in S&C and rehab as well. Do you have any examples of a simple plyometric for each? I guess each person's different and each team uses different things, but we've got the running. That's a great idea of giving us a great idea. But with whether it's hamstring or knee, lower limb mainly, plyometric stuff, how would you initiate some plyos, and how would you build that up from a simple to a complex movement? Have you got any specifics?
I mean, I think the continuum in my head I tend to use, so obviously you start with let me preface it by saying obviously it's different depending on the area of the body and the tissue that you are rehabbing. So I think you need to consider those factors. However, you can sway it either way. And the continuum I would use would be your high to low. So you're kind of like altitude landings, that sort of thing. So you're just preparing the tissue for plyometrics essentially. Then you would progress to obviously your force production or your force absorption. So obviously depending on what tissue you are rehabbing. And then once you've ticked off one of those, let's say you're going force production first, looking at that, then you would look at your force absorption afterwards. And that's all in a linear plane. And then from that, and you could then obviously make it double leg to single leg. And then from that, I would then go to change direction, plyometrics. So again, looking at double leg, single leg, and obviously you can have varieties of that, whether you're landing on an unstable surface, you're adding a perturbation, you're adding a skill set to it, you're making it extensive plyos, or you're doing intensive plyos. So there's lots of kind of routes around it. But that's, I think if you've got an idea of what structure you're rehabbing, then you can work the plyometric continuum around that.
You mentioned the force absorption. You give us an example of one or two things.
So like a depth jump, for example. So you're not doing the rebound, you're just stepping off a box and just landing. So you could obviously start that with double leg, progress it to single leg. You might do a double leg with a quarter turn each way. You could do like a lateral depth jump. So they'd be the force absorption elements of it.
Those are quite important as well. The load acceptance stuff and being able to take that. Have you got any nuggets from your side, Damian?
Just the consideration whether we're trying to produce horizontal force or vertical force, or ticking off both, because different components, but equally as important depending on the tissue. So some examples of horizontal force might be using a sled and doing some bounding with that. So trying to jump as far as you can from one leg as you're pushing the sled along. As opposed to your standard vertical force of box jumps or counter movement jumps.
Okay. Yeah. And that's adding varieties as a change of direction. Yeah. Shoulder injuries. I don't know. We've done a lot of lower limb. Have we got any interesting shoulder injuries that you've had recently? Are we changing it up? Hopefully not too bad, but I guess if you've had any dislocations of the classic, but any of those causing trouble?
We're probably typically.
You go.
We typically have about one instability episode a year on average. So it wasn't a huge incident. It wasn't really high on our list of all the injury surveillance that we had. A couple of pectinid ruptures. And again, I think it's because of that, the space on defense that you're getting stepped at high force and you're throwing an arm out late to try and stop a 100 kg person running past you.
And you're knackered. Yeah. Those pec tears are quite interesting. Have you did surgery, non-surgery? I guess it is also patient specific, or would those guys have been repaired?
So patient specific, but depending on severity, that's almost the opposite of what I was talking about. They tend to be surgically repaired.
Sure. Yeah. No, that's interesting. And with generalized, maybe not necessarily instability injuries with these players, but a general shoulder test battery. Have we got anything that you guys would normally go? This player's passed these tests. We can then start throwing them at people. Have you got any things that still stand out for you that you like to use for shoulder injuries?
I think it's obviously injury specific, but if you're looking at like if it was a dislocation, or if it's a pec tear, or if it's a rotator cuff issue, then you're still working in the same philosophy of your lower limb by looking at your strength, endurance, your isometrics, your capacity type work, ticking that off. If it's a pec tear, then you're looking at that anterior cuff more so. So looking at your ASH-T test, your ASH-Y test, looking if they're able to produce that peak force, opposed to looking at your posterior cuff work, where that's isometrically at 90-90. So you're ticking those off, and then progressing to the rate force development. So still using the same test, but just seeing if they can produce that force as quick as they can. And then from that, you can then look at your plyos in upper body, which I think is probably a little bit more difficult opposed to lower body. But your plyo push-ups from the floor, you can look at some recently people sticking like a VBT on a landmine and doing a overhead push throw to see how quickly they can produce that force in a horizontal way, rather than just like a vertical way. So it's quite interesting. Like, I think people coming up with new ideas how to look at it, because I don't think it's as well researched as opposed to lower limb. It's also more difficult to do, I think, looking at plyometrics in the upper body.
I mean, with not that it directly links, but I managed to get onto Dr. Ian Horsley's course last year, sort of shoulder guru bloke, and he talked about a battery of tests. So you kind of tick off posterior cuff, shoulder blade endurance, upper limb impact tolerance. So there's a couple of tests that you can do there, and then fatigue testing. So just thrashing the cuff and the shoulder blade, parascapular muscles, and then retesting all of that stuff to make sure that their strength, they can endure fatigue. There's a bit of evidence around that. Cardiovascular central fatigue reduces the cuff proprioception to a degree. So I guess that is, as you said, there's so much research in the knee and around there, all the money's at that we're still coming to that. But it's just interesting to ask, because it seems to be a little bit less sure, or people are less sure about how to rehab a shoulder. As you said, there's a nice sort of the Melbourne ACL and the traumatic knee protocols where you use your kind of graded programs, and it's just interesting because shoulders are quite a big problem, or can be, in rugby a lot more than other sports. So it's just something that physios who listening might find that interesting. Have you got anything similar to that, Damian, or other things that we haven't heard of yet?
No, I don't think so. We use the battery test for instability down here, produced by a physio called Margie Olds. So there's a number of things on that test. The hardest really being where basically you're trying to hop from one arm. So you basically push up position and hop across the line.
Yeah, it's pretty rough. How do you, out of interest, we're starting to use a bit more of this in the forces that where I work in, but out of interest, that test, you doing 5 reps for time, or how many reps, or how are you assessing out of interest, the limb symmetry?
As many reps as you can in a time frame. Yeah.
That's pretty hard, isn't it? Unless you've done it, practice it. That's a good paper. It was a 2019 paper from her. Some pretty hard stuff on there for the shoulder. So really interesting. So to sort of nearing the end, if we to wrap it up, it's been great to sort of have you guys on with the kind of back to fitness stuff. How closely are you working with your S&C team? Do you try and train to their standards? This is a topic I've spoken to Damian about with potentially an episode with the S&C coach, but we train and we rehab patients to a certain level that we feel that they're robust enough. But do you feel that at the end of the day that there's a joint decision between yourselves and the S&C team, or do the S&C team set the fitness standards and we have to get them to that? Does that make sense? Or is it the case the coach can go, right, ignore the S&C guys, they come straight to you? Or does it work like that?
So every team will have a different setup, but the gold standard.
I know I'm asking these questions, and it's all so malleable, isn't it? It's
Look, the gold standard is definitely it's a team decision model.
Okay.
And it's easy when you sit down at the start of an injury, if it's a decent enough injury that the person's going to be out for multiple weeks, to set aside time and sort of lay out what the plan looks like, and you've got opportunities at the start to put in what your markers are, what your targets are, and get input from S&C as well as a physio.
Mm-hmm. Once
you do that a number of times for a number of injuries, you sort of realize that you don't really have too many disagreements.
Yeah.
And once you've been doing it for years and years, you basically just create a template from the last time you had an injury similar to this, and sort of say, well, look, this is last time we did that. This is what worked well. This is how this might differ because of this athlete. Anything new to add? So no, any time that you spend with your S&Cs getting on the same page is well worth it.
So then, as physios as yourselves, you've seen things improve, progress. If the S&C guys come along and say, we've got this new test, or we want to thrash the guys to a standard like X, Y, and Z, or then is that then you having that conversation to add that to your template? So it becomes part of your pathway. Does it make sense? If there's a new fitness test or a strength test that the S&C guys have found that we don't know about or you don't know about, and they want to make sure that they hit that test before they get on the pitch, is that also a conversation you hope that they bring up with you, and then you then rehabbing to that standard, or do you hand them over to the S&C guys to then do that testing and then? That makes sense. I don't know. Yeah,
it's an interesting scenario. It never really happened, but you'd like to make sure that the test had some relevance, or you felt like it was relevant to your athlete as a marker of a return to play. And if you agreed that it had some relevance or could add some value, then, and if they needed to pass that test and you agree that they need to pass that test to return to training or return to play, then definitely your rehab would have to reflect that to give them the best chance of passing that test.
Sure. No, that's it. It's just the concept of physios are very good with the yellow band acute stuff. And actually yourselves have got so many years of experience doing high-end strength and conditioning that it probably seems natural for you to just take them into the gym and do a 1 rep max leg press or a really, really brutal testing session. But I think for most physios, it's probably a bit daunting to be able to say, we're going to really test you today. So it's just a bit of an insight into that side. Do you have any on that, Liv?
Yeah, I think with the S&C, you want them involved as early as possible, like Damian said. Like, you're there planning your rehab plan with them. And yes, the initial phases, they're in that protect phase where they're mainly with the physio. However, if it's a lower limb injury, they can still do loads on their upper limb. So then they're doing all their upper limb stuff with the S&C. If it's a ankle injury or in a boot, but the scar's healed, then you can get them to do like a rower with one leg on, like that sort of stuff. So you're bouncing ideas off with the S&C and getting them involved as early as possible. Yeah. And then once they've reached the markers of that phase and they are able to then progress onto the next phase, you're then having that conversation with the S&C saying, okay, I've completed their intro to running. They're able to do this, tolerate this speed. This is the cap. They can be capped at 70% max velocity. You take on their running now, start to build up their cardiovascular capacity from a running perspective rather than a bike perspective. And you're just kind of bit by bit handing them over to S&C.
Yeah.
And it also keeps the S&C in the loop of where they're at, because definitely from my experience, when you're picking up an ACL rehab that's halfway through, it's so difficult to get an understanding of what that person's been through, how they've tolerated things. You're playing catch up a lot. Whereas if you've got the S&C involved from the get go and communicating that transfer over is so easy. You also have an understanding what the S&C's philosophies are of what they're trying to achieve to get that player back, so you can work backwards from that point. Because although you've got your physio benchmarks for what you're working backwards for, you've then got your S&C, and then you've got your sport, so you've got an overall idea of what you're achieving for that player.
No, that's great. This integration, the whole team thing is really important, isn't it? It's just a different really, really cool environment to be in, working almost as an S&C kind of hybrid, really, which is really it's the best part of physio, I think. As you said, not on the wards, which is obviously needed, but really enjoyable.
And as your team gets bigger and better resource, so we had a return to play physio and a return to play S&C as well.
Okay.
So that those people had a lot of time where they work together, and they would have regular meetings around, okay, these are the list of players that we've got. This player, I'll keep programming their lower limb because they're in a protect phase, but you do the upper limb, and you could just go through the list and just quickly work out throughout the course of the week who's doing what. And as Liv said, the ideal standard is that you're gradually releasing control to the S&Cs. But you kind of don't want to feel like that's the case. You don't want to feel like, no, this is my athlete, I'm looking after him, and then all of a sudden it's you. You kind of want this fairly seamless transition towards from injury to performance.
No, that's really interesting.
And then you're just depending on how confident you are in each of those areas, you might be in a team where you're happy to take someone right through to that high performance, but you might also have a season where you've got so many injured players that you just have to deal with the acute, and as soon as the S&C can start doing more and more of the rehab, then that kind of lightens your load as well. So you just need a high trust model that the athletes have been well looked after.
No, that's it. So the S&C guys have an insight into your realm and vice versa. Yeah. That's covered a lot of ground. I'm very grateful for your time. I think it's really appreciated, and it's great to have you on. Have you got any other closing remarks or anything we've missed worth bringing up? No.
Thanks for having us on.
Thank you.
No worries. Thanks for taking your time out for that. So we'll call it a day. Thanks a lot.
Great.